Okay, well, thank you very much for the invitation. I'm a volunteer for Compassion and Choices, which is the nation's oldest and largest nonprofit committed to improving and expanding options at the end of life. We have some members who are working with us, Betsy Mangan, who's in the back, and Elias Lieberman and my wife Kathy, who are part of the steering committee, and Janet Folger, who's also one of our workers, is here as well. So what is our goal? Currently there's legislation, H 1926, the House version, and Senate 1208, and they're identical, an act relative to end-of-life options. We would like this legislation enacted to authorize medical aid in dying. I will talk to you about my work as a doctor, my life as a cancer patient, and why I believe in medical aid in dying, and to also give you the history of medical aid in dying in the United States and in Massachusetts. So first of all, what is medical aid in dying? Medical aid in dying is a practice in which a mentally capable adult with a prognosis of 6 months or less to live requests from their doctor a prescription for medication that they may self-ingest to bring about a peaceful death. Who am I, and why am I qualified to speak about medical aid in dying? I'm a retired internist, which is an adult medicine practitioner, and I practiced over 30 years, predominantly in Brockton, which is a medically underserved area. I cared for people across the continuum, in the office, in the hospital, in nursing homes. I was a hospital attending, and this was very different from what you have now. So my patients got sick and had breathing problems. I took care of them in the intensive care unit as they're attending, the primary doctor in charge of their care. That have a heart attack, I'd take care of them in the coronary care unit. So I was there. Medicine isn't practiced that way anymore, but this is what I was able to do. And I dealt extensively with end-of-life issues in the hospital as well as in the office. I took care of acute and chronic diseases. As a hospice attending, after the oncologist was done with their patients, I'd tell my patient, you come back to me and I'll take care of you. I took care of ordering their medications, adjusting their medications, trying to keep them comfortable, and talking with them about what they wanted done. I also practiced palliative sedation, which is when someone has uncontrollable pain. I would bring them into the hospital, we'd try and get the pain under control. And if we were unable to do that, we would start them on a morphine drip. Now we'd talk ahead of time. They understood that they were going to become unconscious and that they would never wake up again. I also discussed whether to terminate care or whether to start treatments such as dialysis, or people who were going to go on a ventilator for respiratory failure if we weren't going to be able to get them off, if that was a possibility, whether they wanted to live the rest of their life on a ventilator or whether they wanted to be able to die. So I also had patients who wanted to end their suffering and requested medical aid in dying from me. I did not feel that I could comply due to concerns about myself, without evaluating whether this was the best option for my patient. So that's somewhat an ethically challenged point of view. As a doctor, you're always supposed to put your patient's needs ahead of yours. So like most of us, I have a personal side of death. I'm pretty sure most of you do as well. In the 1990s, my wife and I had 6 relatives die in about 18 months. That included my mother, who died of pancreatic cancer, and my father-in-law, John, who died of an abdominal sarcoma, which is a soft tissue mass that was in his belly. It was about the size of a turkey when it was removed. They both had what I'd consider bad deaths. And I decided that I didn't want to die that way. So I was about 40, or exactly 40 at that time, and that's when I decided that for me, medical aid in dying was the way to go. Although I didn't call it that and I didn't have any recognition, I just figured I'm a doctor, I know how to end my life when my time comes, and I don't want to do what they did. Eventually I embraced the concept of justice. So as I started to get older and more mature, I realized that if I could possibly end my life and my suffering, others should be able to as well. And I started in working for medical aid in dying as a social justice issue. So what's my history with my cancer? When I turned 50, I ordered a blood test for screening for prostate cancer. That's what we did back then. And my test was elevated. Eventually I had surgery, and then I had a recurrence of my cancer. I then had treatment again with radiation and hormones to try and effect a cure. Again, it was not successful. In 2011, I had my first known metastasis. The cancer was in my bone of my pelvis. And subsequently, after being treated with hormones, I was treated with radiation and hormones again. And the cancer was incurable. It became resistant to the usual treatment and has given immunotherapy, which has helped somewhat. So, how does the Massachusetts End-of-Life Options Act work? And what are the safeguards that are in there to prevent people from inadvertently being treated? So only mentally capable, terminally ill adults with 6 months or less prognosis are able to get this. So that's the same definition of hospice. It doesn't mean that they'll be dead in 6 months. It means that they're as likely as not to be dead within that time. The person must request this from their doctor, and only they can request it. It's not like the healthcare proxy or the daughter or anyone else in the family can request it. The doctor has to agree that they are terminally ill, meeting the hospice definition, and that they are mentally capable, meaning that they can make decisions for themselves. A second doctor has to concur with the first doctor, that they're mentally capable, that they're terminally ill. A mental health professional in Massachusetts has to agree that they are capable and are making a good decision for themselves. All the options of other types of care have to be discussed with the patient. 15 days after the initial request, they have to give a written request, and the written request has to be witnessed by 2 people, and at least one of those has to be a disinterested party. There has to be no coercion. This has to be voluntary and is rescindable every step along the way by the person requesting this. The individual must self-ingest if they decide to take it. And in other states, about 1/3 of people who get the prescription don't end up taking it because they're satisfied with the way that they're dying or for other reasons. The cause of death is the underlying illness. This isn't suicide, and life insurance and other benefits that the person has are not impinged upon this decision. It's voluntary for the doctor, so the doctor has to agree that he or she wants to be involved with giving the prescription, as well as the pharmacist. And the person has to be a resident of the state. So how have the safeguards worked? In the past 21 years, a bill similar to this has been present in Oregon, and it's been present in other states as well. And there's not been a single case of abuse or coercion, nor any criminal or disciplinary charges have been filed, not one. So I'd say that the safeguards have worked well. Disabilities Rights Oregon, which gives legal help to people with mental and physical disability, gives us a letter every number of years saying whether there have been any problems with the disabled community, and there have been none. Last letter was within the past year. So why do we need medical aid in dying? Medical aid in dying is an option only for terminally ill adults to self-inject a prescription to end their suffering. It gives people peace of mind about their dying process, which I think in and of itself is the million-dollar question. It gives autonomy to the dying person. It improves end-of-life care, which is an unintended consequence, because doctors have to learn how to talk better to people while they're dying. And people die at home more frequently in Oregon now that medical aid in dying is available there. And it virtually ends violent suicide by terminally ill people. So probably about 0.25% of people who have a terminal diagnosis end up killing themselves because they're afraid of what's going to happen at the end, which is almost the same number as the number of people who use medical aid in dying. So how does medical aid in dying differ from euthanasia? Euthanasia is where someone else gives medication or action to intentionally kill a person with an incurable illness or injury. It's illegal in all states, and it differs from medical aid in dying, as medical aid in dying has to be self-ingested. It's typically what you see when you take your animal to the vet, and the vet puts the animal down. Now that's euthanasia. Medical aid in dying is also not suicide. So suicide is a premature death hastened by unrelenting psychological issues such as despair or psychosis. And very much it tends to be a secretive process. People don't talk about, oh, I'm going to go kill myself next week. So for example, someone jumps from a building and ends their life. However, on 9/11, for those of you who remember, on the World Trade Center, there were a lot of people who were stuck at the top, and they knew that they were going to die, either in the flames, the collapse of the building, and some of them decided to jump off the World Trade Center. They didn't want to die, but they made a rational, autonomous decision. So the medical examiner of New York had to make a determination how these people died. He could have marked them as dying from suicide. After considering the options, he decided that this was not suicide, that these people died of a terrorist act, and they were marked on their death certificate of dying as a victim of terrorism. So suicide is almost always secret. Medical aid in dying, on the other hand, tends to be a collaborative effort. Most people talk with their families. Some people don't have families or, isolated from them. But usually this starts months ahead of time, that people start talking with their family about it. They always, and by definition, have to talk with their physicians. So they're talking about this, it's not being hidden, but it's what they feel they need. And the discussion usually goes on for months. This is part of the reason why organizations such as the American Academy of Suicidology and the American College of Legal Medicine, as well as state laws for the states that have adopted medical aid in dying, differentiate medical aid in dying from suicide. So what's the history of medical aid in dying in the United States and in Massachusetts? In 1994, in the middle of the AIDS epidemic, there was an initiative passed in Oregon, and it passed by a little bit. Of course, this being America, things got tied up in court, and the legislature finally said, we're not going to get through this very easily, and we're going to have a recall to see if the voters want to have medical aid in dying or not. And by a larger percentage, the voters said, we want to have medical aid in dying. So in 1997, Oregon became the first state in the country to allow medical aid in dying. After watching for a decade, the people in Washington state also decided that they wanted to have medical aid in dying and did it through an initiative. In 2009, there was a gentleman named Baxter and a number of other people who were dying, and they sued the state of Montana in order to be able to get medical aid in dying, saying that there were no state laws prohibiting medical aid in dying, and that the Constitution of Montana protected them to be able to get this. Mr. Baxter, as is usually the case, died before this became clear, but the courts ruled that there were no laws prohibiting medical aid in dying and did not rule on the constitutionality. And while it didn't help him, his grandson was very happy to be able to get medical aid in dying when he ended up having pancreatic cancer and wasted away. In 2012, there's an initiative in Massachusetts. The polls initially showed about 60-40 in favor of medical aid in dying, but there was a large amount of money put in, predominantly by the Catholic Church, and there was a disinformational campaign. They didn't really talk about the issues, and it went down to defeat by 51 to 49%. In 2013, our neighbors to the north, Vermont, was the first state where the legislature passed medical aid in dying legislation. In 2014, you may remember a woman by the name of Brittany Maynard. She was a 29-year-old woman. Shortly after getting married, she developed headaches and had a brain tumor. After looking at what her options were, she decided to move to Oregon to be able to get medical aid in dying. She was in all the papers, and her dying wish was that California pass medical aid in dying, which they did in 2015 by legislature. And every year since 2015, one state has passed medical aid in dying. So in 2016, Colorado passed an initiative that was 2-for-1 in favor. In 2017, the District of Columbia's legislature voted for medical aid in dying. 2018, the Hawaii legislature. And just last Friday, the governor of New Jersey signed legislation, and as of August 1, New Jersey will have medical aid in dying. Cuomo in New York has said, come on guys, I want to sign a bill. So hopefully New York will join them. But as of now, 22% of the country has medical aid in dying. And there have been 5 states in 5 years that have passed legislation. In Massachusetts, there's been a bill submitted every year, or every session, which is a 2-year period, since 2009. It has not made it out of committee. And the legislature wants to see broad support, that people care about this. And that's why we're here, asking for your support as well as other civic and religious groups to show that there is support for this. So who supports medical aid in dying? 70% plus of the people in Massachusetts and nationally endorse medical aid in dying. Absolute majorities, that means more than 50% of people who are white, Hispanic, and black support this. All age groups, young people, middle age, older people support this. It's one of the few issues that's bipartisan. Democrats and Republicans support this. Liberals, moderates, and conservatives, again, all by absolute majority. Religious and non-religious people, including 70% of Catholics, but not the hierarchy, and 70% of other religions, and over 50% of other Christians. So over the past 21 years, who are the people who tend to use medical aid in dying? 3/4 of them are people like me who have cancer. 11% have neuromuscular disease, such as ALS, Lou Gehrig's disease, where they gradually lose their muscle strength and they're not able to swallow, move, breathe. It's not a pretty death. The median age is about 72. Over 90% of the people use hospice. This is not an anti-hospice or anti-palliative care legislation. Hospice and palliative care are great at the end of life. And people who go to hospice and use hospice appropriately end up living about 5 weeks longer than people who get usual medical care at the end. So the unintended consequence is that this tends to improve end-of-life care for all. It doubles the use of hospice, and the hospice use tends to be appropriate. The only state in the country where more people die at home than in the hospital is Oregon. And that's where people want to die for the most part. It also ends violent suicide by terminally ill people. So what problems do people report as to why they want to use medical aid in dying? 95% of the people say that they're losing autonomy. And 95% they're less engaged in activities that make their life enjoyable. So they're sick while they're dying, and they're not able to live a life that they feel is, valuable to them. 87% feel a loss of dignity. 56% feel a loss of bodily function. About half the people feel that they're a burden on their family. Inadequate pain control is 25 to 30%. And you'll see this in many studies, that in spite of hospice or palliative care, in spite of the best medical efforts, 1/4 of people end up dying with uncontrollable pain. 5% say it's a financial burden. And although not asked, about 21% of people die with a chronic disease with uncontrolled shortness of breath. So how do people use medical aid in dying? They drink medication. So they get the pills, it's mixed in a liquid, 3-4 ounces, and they have to drink it down quickly, or else they'll fall asleep without taking a fatal dose. So with Seconal, which is the most common agent used, the median time till people fall asleep is 5 minutes. And the median time to death is 25 minutes. And these, of course, can be variable. And it's 3 to 4 deaths per 1,000 people who die in the states where it's available. So in the 21 years, 1,459 people have taken prescriptions and died from medical aid in dying, and 2,217 have gotten the prescription. So again, 1/3 of people have gotten the prescriptions and not used it. So in conclusion, medical aid in dying is an option for capable adults with a terminal illness to have a peaceful death surrounded by loved ones and avoid unnecessary suffering and a prolonged dying process. We seek to show broad support to the legislature. So I've got a few asks for you. First, I'm asking that as an organization, the Mashpee Democrats endorse medical aid in dying and the legislation. We have petitions that are in the back for people to sign or to put their names down. And basically this is so that we can email you and show it to your legislature. So if you can put your email and zip code. We'd like for people to join Compassionate Choices, which is free. Just go on the website, and there's information again in the back that you can get to just go online. And we're also looking for people to work with us. Betsy is organizing Mashpee, and we're trying to get the word out. This is really a grassroots effort. And on the petition, there's a checkbox, and if you mark the checkbox, we'll be in contact with you. So we're trying to organize Mashpee to educate people so they understand what the issues are and to get other endorsements. For those of you who can do it and feel that this is inappropriate, it is a charity, and if you could send money, like many other things, there are lots of us volunteers, but money helps. And if you would thank Julian Sear, who's your senator, that would be greatly appreciated. He's a co-sponsor of our bill. Unfortunately, David Vieira is opposed to it. And if you feel so inclined, you can ask him and tell him that this is important to you. Well, thank you very much for your time, and I'll take questions. We have literature in the side room off to the side, and we also have the petitions that I talked about. Thank you very much. Any questions?
I mean, it sounds crass, but you mentioned that it doesn't affect life insurance. How does that work? Is it through a state law that says you can't?
Exactly. So the question is, how is it that it doesn't affect life insurance? And so it's in two ways. Number one, it's specifically put in the bill that people who use medical aid in dying are dying of their underlying disease. And the death certificate is also put in with their underlying diagnosis, and the law prohibits insurance companies from withholding payments. Yes?
In hospice, it is the nurse or the attendant that prescribes the medication, not prescribes it, but administers the medication, the morphine, whatever it might be, to lessen the pain. Does that mean that probably the patient has not agreed to this?
I'm sorry, I'm not quite sure exactly. what
In other
you're
words, the
asking.
nurse is administering a medication to lessen, to diminish the pain.
Yes,
Okay. Does that mean that the patient has not agreed to this?
no. So people can, the question is, have people agreed to medical aid in dying in hospice
Right.
and getting pain medication? So first of all, it's not available in Massachusetts, but let's say they're in Oregon and they're on hospice. They will still get medications to attempt to control their symptoms. And if that works, that's great. The person doesn't need to do anything further. But if they're still suffering and the hospice and the physicians are not able to get their symptoms under control, the person then has the option of saying, you know, my life really is not where I want it to be. I can't tolerate this anymore, and I'm ready to die. And it's usually a short time before, but sometimes the suffering that goes on can be really severe, you know, at the end of life.
But they have to be alert and oriented to take the fatal dose.
I
So they're
understand.
agreeing to it, just like they would agree to morphine or Ativan under hospice.
But they don't always agree to it in a hospice agreement. They don't disagree with it, but
Well,
I think
this-
she's not talking about MAID, she's talking about the palliative care, the medication if somebody's on a morphine drip. And if they want more medication, they have to ask for it, the nurse just doesn't give it to them. I don't think she's talking about MAID, and she's talking about the palliative sedation you were talking about.
Is that what you're asking?
I am, but
So for palliative sedation, once this is started, the person is no longer competent. And this is not covered under medical aid in dying laws. This is something that's separate and something that's available at this point in time. So I had probably 4 people that I used palliative sedation for during my career as a physician, and it was all ironed out beforehand. It's legal, it's authorized, it's acceptable, it's considered morally acceptable, you know, even in the Catholic Church, you know, there's no pushback from that. It's just because you're trying to make the person comfortable rather than trying to cause their end of life, although it does both. Well, thank you very much. I appreciate your having me here. And yes,
One question, Roger, for me, like a clarification between the palliative sedation and the medical aid in dying seems to be that if you want to be alert and say goodbye to your family and choose a particular time and say, I don't want to get to that place where I can't control the pain anymore, that you can use medical aid in dying in a sort of comfortable setting at home and say, I want this music playing, I want my family here, and you can choose the time to do it. Whereas palliative sedation, you're on a drip, and as you get more medication, you go out of it, and you're not really able to time it with having family there.
so you're asking what's the difference between palliative sedation and medical aid in dying? It sounds like that, but that's not true.
Okay.
So basically, with palliative sedation, the person has been suffering for quite some time. They haven't made a decision, and often it's not even offered to the person at the end of their life. So they just end up being suffering. If it is offered, it's not offered, it's not their choice to have this, it's based upon the physician. So the physician is in control of this, whether or not it's done. Medical aid in dying puts the individual in control of their fate. And when they determine that their suffering is too much, they're able to take the medication and end their life. They don't need to get permission or consent of anyone else. It's their decision, it's their autonomy. And there's a big difference between palliative sedation and medical aid in dying. And having practiced, I can tell you it's not the same.
And isn't it typically a longer dying process in palliative sedation than
Palliative sedation can go on for days, so the person doesn't get food, fluids, medication, and the family is sitting around watching this person who's unconscious usually, and having all the things that happen as the body starts shutting down. So they start to breathe funny, or they move funny, and the family, is watching their loved one, and it's a very hard period of time for them. The person should be okay, and their pain should be controlled, but as far as the family goes, this is a really difficult thing for many of the families to watch.
Thank you.
Any other questions? Thank you, Roger.
Thank you very much.